Tuberculosis in COPD patients. Chronic obstructive pulmonary disease (COPD) is a progressive lung disease characterized by persistent respiratory symptoms and airflow limitation due to chronic inflammation in the airway and alveoli. So, let's talk about the tuberculosis. Tuberculosis TB, a communicable disease caused by Mycobacterium tuberculosis, remain a significant health burden worldwide. The coexistence of COPD and TB present unique clinical challenges due to compromised lung function, altered immune responses, and increased morbidity and mortality. So, today I am going to talk or explore the intricate relationship between tuberculosis and COPD and emphasizing its epidemiology, clinical manifestation, diagnosis, treatment, and preventive strategies. So, COPD patients are highly susceptible to respiratory infection due to impaired mucociliary clearance, chronic airway inflammation, and immune dysregulation. Tuberculosis primarily affects the lungs. Thrives in condition of chronic lung damage leading to an increased risk of TB infection. Reactivation of latent tuberculosis and poor treatment outcome. TB in COPD patients can accelerate lung function decline. It increases hospitalization rates and worsen overall prognosis. So, in overview, the interaction between COPD and tuberculosis is bidirectional. COPD as a risk factor for TB, chronic inflammation, structural lung damage, and long-term use of corticosteroid predispose COPD patients to TB. TB exacerbating COPD. It's increased the attack. TB induced lung fibrosis and cavitation contribute to worsening airflow limitation leading to increased COPD severity. In treatment challenges, TB treatment in COPD patients is complicated due to drug interactions, side effects, and coexisting comorbidities such as malnutrition and cardiovascular disease. Epidemiologically, the global prevalence of TB is approximately 1/4 of the infected person and 10.6 million cases per year. That is the incident rate, with a significant burden in low and middle income countries. that is LMIC, where the COPD prevalence is also rising due to smoking and biomass fuel exposure. Studies indicates that COPD patients have a 2 to 4 times higher risk of developing acute TB compared to the general population. The prevalence of latent tuberculosis in COPD patients ranges between 20 to 40% depending on the geographic location and TB burden. TB related mortality is higher in COPD patients, especially in an elderly population and those with advanced airflow obstruction. Clinical manifestation: TB in COPD patients often present with atypical or overlapping symptoms, making early diagnosis challenging. Common symptoms: respiratory symptoms, chronic cough, worsening dyspnea, that is breathlessness, increased sputum production, hemoptysis. Systemic symptoms are unexplained weight loss, night sweat, fever, tiredness or fatigue, exhilaration like presentation. COPD patient with TB may experience frequent acute exhilaration that do not respond to standard bronchodilators and corticosteroid therapy. In severe cases, pulmonary fibrosis and cavitation lead to irreversible lung damage, causes pneumothorax and respiratory failure. Occurs in advanced TB cases with COPD. Investigation and diagnosis. In COPD, TB in COPD. First is a microbiological test, sputum smear microscopy, acid fast bacilli, AFB staining for TB detection, gene expert, MTB or and RIFA resistant, that is MTB, rapid detection of Mycobacterium tuberculosis and rifampicin resistant. Mycobacterial culture, it is a gold standard for TB confirmation. Radiological studies, chest X-ray, pulmonary infiltrates, cavities, fibrosis or pleural effusion. High resolution CT, that is HRCT scan, differentiate TB from COPD related lung changes and detects early TB lesions. Immunological and blood test, interferon gamma release assay, that is IGRA, detect latent TB in COPD patients. Tuberculin skin test, TPT, TST. Limited use in COPD due to immunosensitivity. Complete blood count CBC may show anemia and leukocytosis. Pulmonary function test PFT identifies airflow obstruction in COPD, differentiates TB-induced fibrosis from COPD-related emphysema, treatment and management. First is a anti-tuberculosis therapy, that is ATT or ATT. Standard regime, 6-month treatment with isoniazid, that is H, rifampicin R, pyrazinamide Z, and ethambutol, that is EHRZ, for 2 months, followed by isoniazid and rifampicin with ethambutol for 4 months. Drug resistant TB DRT requires longer treatment with newer drug like bedaquiline, repurposed drug like linezolid, and fluoroquinolone like leofloxacin. COPD management in TB patients. Bronchodilator, long-acting beta-2 agonist, that is LABA, and anticholinergic, that is LAMA, for airflow relief. Inhale corticosteroid ICS used cautiously as they may increase TB risk or TB disease. Oxygen therapy for patients with advanced COPD and hypoxia. Pulmonary rehabilitation to improve lung function and exercise tolerance. Drug interactions. Consideration: rifampicin induce cytochrome P450 enzyme, reduce corticosteroid efficacy. Isoniazid induce hepatotoxicity in exaggerated in COPD patients on long-term medication. Supportive care. Nutritional support, high protein diet to counteract weight loss, vaccination, influenza and pneumococcal vaccine to prevent secondary infections. Prevention strategy. First is smoking cessation. Tobacco smoke is a major risk factor for both COPD and tuberculosis. Cessation program should be integrated into COPD TB management. Latent TB screening in COPD patients. High-risk COPD patients, for example on corticosteroids, should undergo IGRA testing and receive isoniazid preventive therapy, that is IPT, if positive. Infection control measures. Personal protective equipment that is the PPE, mask for TB patients to prevent transmission. Ventilation and air purification, reducing airborne TB spread in healthcare and community settings. Regular monitoring, spirometry and chest imaging to track lung function decline. Adherence to anti-TB treatment and COPD medication prevents relapse and exacerbation. Further future prospective personalized medicine, use of biomarkers to predict COPD patients at high risk for tuberculosis. And in conclusion, tuberculosis in COPD patients remains a major clinical and public health challenge due to diagnostic difficulties, overlapping symptoms, and treatment complications. Early screening, timely intervention, and a multidisciplinary approach are crucial in improving outcome. Thank you.